Okay, so looking at this GI PowerPoint here, let me maximize the screen so you can see that. Okay, so assessment-wise, a lot of the pediatric history that you take addresses their feeding dietary style and always asking about constipation and diarrhea. Can't overestimate or overemphasize the addition of that history as far as constipation and diarrhea to your pediatric history, because like I said before, there's so much GI complaints in pediatrics, so much of it is leads back to constipation. So we want to make sure we're asking about bowel movements in all ages of our pediatric assessment. And then I just wanted to review the different levels of pain or locations of pain and kind of what those are associated with. So certainly epigastric pain when we think like with reflux, and periumbilical, a lot of times we see that with constipation and backing up into that ascending colon, and then lower abdominal pain and suprapubic, and then acute abdominal pain. So making sure that we can kind of identify where the pain is located, even if the child is not able to verbalize that. And then think about what is going on in that area within the body where their pain is located, and also remembering that there's a lot of referred abdominal pain too. So we need to keep that in the back of our mind as well. So looking at their BMI, making sure that they have had normal weight gain. Certainly if you have frequent constipation problems along with a failure to thrive or poor weight gain, that puts you in a risk factor for cystic fibrosis, or at least needs to be worked up for that chronic constipation and failure to thrive. Again, if you have a poor weight gain or slow weight gain and recurrent diarrhea or vomiting, then that is going to help with your diagnosing as well. So just kind of review the physical exam part as far as GI assessment. We don't do a lot of rectal examinations in pediatrics other than at that initial newborn exam. Definitely we have to check for anal, make sure that the anal is patent and check the rectal tone. And then we don't really do that routinely unless there's a problem with constipation or like leaking of stool or something. And then also the GYN exam, don't do that very often unless there's a clinical indication for that. Certainly we check pubertal development, but as far as doing actual pelvic exams and things, we don't require that very often for our diagnosis and treatment. So here's just some different diagnostic studies that we're going to talk about for the various diagnoses, and different imaging studies that we'll do in pediatrics. Most of the assessment and imaging studies you do in adults, we can do these in a pediatric radiology center as well. So starting with the most common, vomiting and dehydration, we see tons of acute gastroenteritis in the clinical setting. And so it gets really difficult to tell sometimes at what point we need to be concerned about a child who's vomiting. And also trying to determine, is this just an acute problem or is this something that's been going on as a recurrent problem? And so I wanted to point out the third one down, projectile vomiting. Anytime that you hear or see the description of projectile vomiting, it can come from the central nervous system, but also in infants. This needs to be a clue you to the possibility of pyloric stenosis. And pyloric stenosis is really a diagnosis of infancy where they drink their formula or their breast milk, and they drink because they're very hungry, and their stomach fills up as far as it can. And then that pyloric sphincter that needs to relax in order for the stomach contents to empty down and go through the rest of the GI tract is enlarged. And so it's a tightened muscle, and that sphincter won't relax. So what happens is the stomach fills up almost like a balloon to its maximum stretching capacity, and then it just projectilely pushes all of the milk or formula, breast milk or formula that they've taken in, and it literally shoots across the room. So this slide has CNS on here, but also add to that pyloric stenosis and read about that. And often you'll feel that it's described as like an olive-shaped mass in the abdomen of an infant that has these projectile vomiting symptoms. And so you have to send them to get an ultrasound of their pylorus, basically, and it's looking at that pyloric sphincter to make sure that it is not hypertrophied. If it's too large, then it's not working properly, and so that's why nothing is passing through. So these babies will lose weight and can have trouble gaining weight, but they are extremely hungry because they are not getting their calories that they need. So they're vigorous eaters, but then everything projectilely comes up. And so these are just, again, some different stages of life, and the most common causes of the vomiting and dehydration. Certainly we talked about GERD with infants. We'll talk about several of these diagnoses, but just knowing what age they're the most prevalent in will help you with your diagnosis. So we definitely need to commit to memory the levels of dehydration. So what is dehydration? It's loss of water and extracellular fluid. Okay, and so we need to, number one, stop the vomiting and replace the fluid, because we have talked before about how infants and young children are composed of a greater percentage of water than adults are. So they are at a much higher likelihood of getting dehydrated from acute vomiting and or diarrhea. So mild, moderate, and severe, less than 3% in older children and less than 5% of loss of fluid. And you can tell this by their weight. So that's a really good thing to have. If you have a recent weight on an infant or a child, and then they come in sick and they have lost, a couple of pounds, then that's easy to calculate what percentage of fluid they've lost, because we know that they've, we're losing that fluid before anything else. And so if our weight drops, that is most likely water weight that we have lost. So want to make sure you have an accurate weight and weigh those children, and that will help with the classification of what stage of dehydration that they are at. So what's really interesting is that current research shows that mild to moderate, and even sometimes with the severe, but mild to moderate dehydration can definitely be resolved with oral rehydration solution. So that is essentially Pedialyte. We know that even so mild, definitely with oral rehydration, and now even moderate, we can just get the vomiting under control, and we can rehydrate with sips of like Pedialyte is the most common oral rehydration. And viral gastroenteritis is the most common cause of diarrhea and the most common cause of dehydration. And again, children are at the greatest risk because they have more body surface area, so actually more like skin compared to the size of their body. And they're also not able to tell us when they're thirsty a lot of times. And when they start feeling uncomfortable, the first thing they want to do is just to close off and not take anything to eat or drink. And so that's one of the biggest risk factors for dehydration. And we want to, we take dehydration in young children and infants very seriously, because we know that once we start getting into that fluid electrolyte balance, everything is affected in our body, and also we can lead quickly to hypovolemic shock. So you want to make sure that we can identify the signs and symptoms of dehydration in kids. So again, oral rehydration solution, which ORS, that's just like Pedialyte, for mild to moderate dehydration. IV fluids in the emergency room or inpatient, sometimes in the outpatient setting if dehydration is severe. So we have to replace what's been lost and get that to our initial rehydrated stage, and then we have to make sure that they're replacing every time that they have a loose watery stool. And then refeeding, I know everybody's heard of like the brat diet, the bananas, rice, applesauce, toast. Refeeding should begin as soon as they are able to help with the GI symptoms. And then we do use antiemetics like Zofran in children. And then again, treating fever to make sure that they are comfortable. So let me tell you here, go ahead and highlight, monitor urine output, because since children cannot always tell us how they're feeling, knowing that they have had urinary output and documenting that they have had urinary output at least every 6 to 8 hours is essential. So you need to make sure that if it's an infant, they've had a wet diaper, or a young child, that that the parents are monitoring that they at least every 6 to 8 hours they are voiding. Most of this can be managed in the outpatient setting, except if they need IV fluids and that's not accessible in your clinic. There's been, I can't even think of how many children we've kept out of emergency rooms just by giving them a dose of Zofran in the office, and then after about 30 minutes starting sips of oral rehydration or doing Pedialyte popsicles. Popsicles are good because they just offer a small amount of fluid at a time. And so it's the same as taking like a one sip every, like a teaspoon every 10 minutes, which is a standard recommendation for rehydration. So GERD, we've kind of talked about that already. I wanted to point out that there is a difference, and there's an article that I think you guys read on the difference between gastroesophageal reflux and gastroesophageal reflux disease. So it is a normal process. All of us throughout the day, every day, have some stomach contents that reflux up from the GI tract up into the esophagus, okay? But when that reflux becomes painful or causes weight loss or causes respiratory symptoms or pain from esophagitis, from the acid coming up, that's when the when the gastroesophageal reflux moves to a gastroesophageal reflux disease diagnosis. So in infants, we want to make sure parents understand that there are happy spitters. So if a baby is gaining weight well and just spitting up small amounts after every feeding, that's normal. So your textbook has several good charts and things on GERD. I wanted to point out in infants, this torticollis or neck arching, that is something that with GERD we see in infants, like after they'll eat, they try to elongate their torso and to try to relieve some of that epigastric pain they're having from the reflux. So that is something, so you'll hear parents say they kind of arch their back after they eat, and that is a classic red sign, red flag that there's some underlying GERD, because some babies do not spit up. They have what we call silent GERD. And so they can be refluxing and having all these symptoms and not actually spitting up. And so it's good to know the other physical examination findings that go along with reflux in case they're not actually having any milk or come back up. So we talked a little bit about the pH probe. That is truly like the kind of gold standard diagnosis. So we treat in the primary care center or primary care practice, we can go ahead and treat symptomatically, see if they improve, and if there is an improvement in symptoms, then we can go ahead and assume that that's GERD that we're treating. And then if they are needing long-term management, referral to a GI specialist for further testing. So here is an algorithm out of your textbook. And I wanted to point out on here, again, that if they are having signs of complicated GERD, yes, we want to do more, but no, if they're not, then that blue box, they're uncomplicated infantile gastroesophageal reflux. And those are called, quote unquote, happy spitters. We can basically just reassure the parents and educate them that this is just a normal process that babies spit up, and also educate them on the how small an infant's stomach capacity actually is. And if you fill up a little small cup with the amount of milliliters that is able, that a cup could hold, based on the infant's age, that's a really good way to show the family, like, hey, at this age, your infant can only hold 10 cc's in their stomach, or 30 cc's in their stomach. And so we see that in the first couple weeks of life, people that are trying to feed, 3-ounce bottles or 4-ounce bottles to their infants, certainly that milk is just going to come right back up if they're overfeeding. So make sure we're not overfeeding. And then this says consider thickened formula. And I wanted to talk a little bit about that before we move on. The thickened formula, you can add 1 tablespoon of rice cereal per ounce of formula. To thicken formula, and in those infants that are spitting up a lot. So if we have kind of mild GERD, or if you have the happy spitters that are spitting just a whole lot amount of formula, and it's more of an annoyance type thing because they're spitting so much, and you've made sure that they're keeping them propped up right after feedings, make sure they're not overfeeding. Talk about the stomach capacity of the infant. If they're already doing all of those things and burping the infant frequently, that they're still spitting up large amounts but gaining weight, you can thicken their formula, and you can also do that to try to alleviate some of the pain or discomfort that comes in with infants that have actual GERD. So you can reassure them that once the baby becomes more upright and they're able to sit up and stand up on their own, this is going to go away for the most part. So moving on to acute abdominal pain. This is something that, we just want to make sure that we don't take lightly or don't miss in the clinical setting. Often acute abdominal pain can just be from gastroenteritis, but it can also be an underlying urinary tract infection. It can be constipation, but there's a couple diagnoses that we don't want to miss, such as appendicitis and intussusception and testicular torsion, which is a referred pain up into the abdomen. So just kind of, again, file that in the back of your memory that in a male that presents with sudden onset of acute abdominal pain, they definitely can have testicular torsion. And also remember that no testicular pain is normal in children, or adults really, but we want to make sure that's always addressed, because that can be an emergency situation if we have a testicular torsion. So appendicitis, we still have that same clinical symptoms as we do in adults. With the right lower quadrant pain, and usually They'll have some fever, nausea, elevated white blood count. One way, kids, when you push on their stomach, sometimes everything hurts, quote unquote. And so it's hard to localize and find exactly where the pain is coming from. But one thing that really works, besides checking for rebound tenderness in children, is to have them stand and jump up and down, which most kids on a good day are going to enjoy doing. And that will stimulate that peritoneal irritation from an inflamed appendix. And if that causes, a significant amount of pain, then we really need to send them for further diagnostic studies and evaluation for appendicitis. Also, if they're unable to climb up and down the exam on the exam table without really severe pain, that's another way to check and make sure that it's not an appendicitis that you're dealing with. So the average age of appendicitis is 6 to 10 years of age. Perforation is more common the younger the child is, and a lot of that is just their inability to communicate the pain. But we do know that as the appendix gets more and more inflamed, it becomes necrotic and it'll perforate, which can cause peritonitis and really a sick puppy. So we want to make sure that we always keep appendicitis in the back of your mind. You don't see it a whole lot, but you don't want to miss it either. So also note that the pain in the right lower quadrant and the nausea and vomiting it may start periumbilical, and that's not on the slide. So you may want to add that. So a lot of times it starts periumbilical, this more generalized pain, and then it will actually kind of relocate and it'll be more fixed in that right lower quadrant. Most of these children don't want to eat. A lot of times they don't have bowel movement for a couple days, and the fever part they may or may not have. Okay, so also remember that last pointer there, that perforation leads to lessening of symptoms. So a lot of times this acute abdominal pain may actually get better after it perforates, but then the child will quickly become increasingly ill. So just some different ways to test for appendicitis. CBC with diff to check if there's an elevated white blood count. CT is a CT scan of the abdomen is the most accurate or precise way to test for appendicitis, abdominal CT. You can do an ultrasound or send them for an ultrasound just to make sure that they're not seeing an enlargement, but that is pretty, it is pretty highly sensitive, but certainly abdominal CT is going to be the most accurate. Kind of talked about this, but these are the main signs with that localizing pain after the periumbilical pain. And sometimes the parents will report that the whole way there to the office, they were crying every time they'd go over a bump. So it's really that up and down or the jumping that should clue you in on the peritoneal irritation. Okay, intussusception. This is a fairly uncommon but important abdominal emergency. Most common cause of intestinal obstruction from 3 months of age to 6 years of age. So again, this is something we want to file in our memory and not miss, especially because we see this in young infants sometimes. But what you'll see with this is a sudden, so the key here is a sudden onset of this severe pain, and it's paroxysmal. So they'll have periods where they're calm and relaxed and normal, and then they will pull their legs in and scream and cry and have abdominal, colicky abdominal pain. And what's going on is that part of their intestines is actually overlapping and telescoping in to the adjacent part of the intestine, and that causes some hypoxia and can cause necrosis and death if it's not resolved, death of that tissue there. And so what you see when a child is having these spells or paroxysms of this severe abdominal pain, usually they will have a bloody stool, and it's kind of like a jelly consistency. And what's interesting is a lot of times this can be like a post-viral occurrence. So maybe a week or two ago, the child had a stomach virus or had upper respiratory infection, then they were perfectly fine, and now they're having these bouts of severe abdominal pain. The way that we test for this is also the way that it's resolved. So if you suspect intussusception, and again, here's a picture of the dilated telescoping part of the intestines there. It's almost like I always think of it as like a lightsaber. When you know, the toy lightsabers you can sit, that kids used to play with, and they just fold back in on themselves. That's a good demonstration of kind of what is happening in the intestines at that time when they're actually having those spells. You may feel a sausage-shaped mass where the intestines are telescoping there, but the way that we treat it is a barium enema, and so that actually will diagnose it, and it also hopefully will resolve it. So like the barium enema the barium's so thick that it pushes the telescoped portion of the intestine out and pushes it back to its normal shape. And that also is diagnostic too. So they can actually see it happening on x-ray while they're doing the barium enema. Abdominal ultrasounds are also helpful in diagnosing intussusception. So I wanted to just point out a couple different types of acute diarrhea. We know that, food poisoning obviously is something that both adults and children can get. There is some bacterial infections that require antibiotics in children as well, and I have a slide that goes over that. We are very prudent about putting children on antibiotics for bacterial diarrhea sources. Salmonella and those type infections often will resolve on their own, and so sometimes it's not even indicated to treat and just let the bacterial infection run its course. And so there's guidelines specifically on which ones to treat and if to treat or not to treat. We don't recommend anti-diarrheals such as like kaopectate and Imodium and things like that, because of the possibility of the infection, the diarrhea being a bacterial infection, and truly that bacteria needs to get out of the body. And so we don't want to stop the body's natural process of eradicating that bacteria, because kids can get really sick with those toxins that the bacteria are producing. So normally we let the diarrhea run its course. Probiotics such as lactobacillus can help restore they can help with acute diarrhea, and they can also help if a child is on antibiotics and that's what's causing the diarrhea. Some people are using peppermint oils and some alternative therapies to help kind of stop those stomach spasms. But I did want to point out that anti-diarrheals are not usually used in children. So here's some common viral causes of gastroenteritis, and certainly we've heard of rotavirus. Now we have a vaccine for rotavirus that used to cause so many hospitalizations for infants and young children. And now with the rotavirus vaccine, the number of hospitalizations for dehydration from rotavirus has gone down significantly. Norwalk virus, that's when you'll hear breakout in crops, like on cruise ships and things like that. But we need to know that and reassure parents that a viral diarrhea illness may last up to 2 weeks. So they may have diarrhea for several days. If the symptoms worsen, or if they have fever or blood or mucus in the stool, then you will consider doing a stool culture, a stool for ovum parasites, and for white blood cells. So, it's hard sometimes to know, when do we get a stool culture? Well, it really is if they have blood or mucus in their stool along with fever, and we think that there's a bacterial source. That's really what we're trying to find out. Or if the diarrhea is getting worsening instead of getting better, towards the end of that 1 to 2 week range. And here are some of the more common bacterial gastroenteritis causative agents: Salmonella, Shigella, and E. coli. Salmonella, again, that will break out, and we see that and kind of pop up in different areas. And Shigella, same thing. So you see with Shigella, they have blood, mucus, pus in their stool. That does need to be treated with antibiotics mostly, but again, these are self-limited and will go away eventually, but you can get really quite sick and dehydrated from these infections. E. coli, I wanted to point out that one of the main concerns with the E. coli bacterial gastritis is hemolytic uremic syndrome, which basically, this is after a week or two after having this horrible E. coli stomach infection, that finally goes away, and then after you clear up the E. coli, there's an autoimmune type response to the kidneys, and you can have this Coca-Cola colored urine where from the blood, you have like acute visible blood in the urinary output. So you get this hemolytic uremic syndrome that can occur after an E. coli infection. So anytime you have a patient that has like gross hematuria and that's causing that Coca-Cola or tea-colored urine, that's why we ask about any recent diarrheal infections, because there's a certain strain of E. coli that can cause that. So again, dehydration, but this slide also has the actual dosing for mild to moderate dehydration in our children that have stomach viruses or that we're concerned about getting dehydrated. 50 mLs per kilogram plus whatever they've lost in the stool. So that's an estimate over 4 hours. So in a child that's 20 pound, or let's say a 20-pound child, you can say they're roughly about 8 or 9 kilograms. So we're looking at about 400 mLs. Let's see, 8 times 5 is 40. Yes, 400 mLs over 4 hours. And so there's, this is just kind of a way to calculate that we're rehydrating. And so we can tell them objectively. And the best thing to do is to write this out on a prescription pad or something, have some specific instructions of how much Pedialyte to give. But tachycardia, dry mucous membranes, decreased urinary output, which we talked about that, and weight. So I would put a star by the decreased weight and decreased urinary output, because those are the two things that are going to be the easiest for you to find. And moving on to the opposite end of the spectrum is constipation. And Miralax, milk of magnesia, Caro syrup, all of these are used and can be used in pediatrics. Definitely need to increase fluid and fiber. We kind of talked about that, but we talked also about constipation that can lead to reflux, and it can also lead to urinary tract infections from holding stool, and it also makes the child hold their urine in as well, and they get infection from the urinary stasis. So we talked a little bit about that already, so wanted to move on to intestinal parasites, which are always fun to think about and take care of. Most common of these here in the United States, depending on where you live, like when we travel to Haiti, pretty much every child that sees a medical provider there or that is hospitalized is treated for worms because they have they have roundworms. They have several different species of worms, intestinal parasites that will cause abdominal pain, frequent abdominal pain. And a lot of times they'll be actually admitted because of abdominal pain, and it's all secondary to intestinal parasites, and they get really malnourished as well. But here in the United States, we are blessed to only have to take care of pinworms as the most common pediatric helminth infection. And we know that this can be treated with a 100 milligram chewable tablet of an anti-helminth. So depending on what, these kind of go on and off the market in different ones, but now there is back on the market a chewable Vermox type medication that you only have to use one time. You may need to treat the whole family if anyone else is having symptoms, because what happens is kids will, especially when they're like potty training or after they've potty trained, if they are not washing their hands, unfortunately the eggs from the pinworms get trapped underneath their fingernails. And so, we see kids kind of reaching down and scratching under their diapers and things like that. And then they go and touch tables and things. And then the next child comes and touches the table and puts their hand in their mouth to eat. So it's not really appetizing to think about, but that's how it is transferred. And the main sign of pinworms is perianal itching, so and irritation. So you may have a red inflamed perianal area or perineum even. Sometimes vaginal itching can be from pinworms. You're not going to see these in the clinical setting because the pinworms only come out at nighttime. And so you can either just treat the patient, which is the most common approach to this. For rectal itching, you can just go ahead and treat them with medication for the pinworms, or you can have the family do the Scotch tape test, which is where they put a little piece of clear Scotch tape over the anus at nighttime, and in the morning, if they have pinworms, they will see something like this with these little white specks on the tape. So that's probably, I don't think I've ever asked them to do the test. I think I've always just treated. But if you need to know for sure, you can do the Scotch tape test, or you can just go ahead and treat for suspected pinworms. But do know that's highly contagious. You want to tell the parents to make sure that the children are washing their hands. You want to have them keep their fingernails cut very short and clean, and try to prevent that itch, scratch, not wash hands cycle. There's not really any reason not to treat if you suspect that they have pinworms, and it's pretty common, especially in certain areas. You'll see like it break out in daycare areas and things like that, different groups of children. So moving on to some psychosocial causes of abdominal pain, I wanted to point out that there is something called childhood functional abdominal pain, which basically is recurrent abdominal pain without any organic cause. This is pretty common, and there's specific criteria to diagnose functional abdominal pain in children, and that's what the FAP stands for. So children that have this pain that is at least once a week or more for 2 months. So this is like a recurrent complaint of abdominal pain, and it may be continuous or episodic. Really, everything else is negative. There's no evidence of any other inflammatory process or anything else, any other cause for their abdominal pain. But I wanted to point out that this pain is genuine. Like they're not lying about this or creating this. Their stomach is hurting. A lot of times this is like a psychosocial pain that they're feeling or psychosomatic pain. And there's certain personality types like perfectionism in children that will, or predisposition to pain. Some kids that are just, some children have a lower pain tolerance than others. And then also how their parents react to the pain. So they can get into a cycle of kind of a dysfunctional response to them saying they have a stomach ache or pain. And a lot of times they'll have some other somatic symptoms. So this is a good example of why at the pediatric GI doctors, they have a full-time therapist there, like a psychologist there. You test for all of the physiological causes of abdominal pain in children, and when all else is negative, the vast majority of the time, there's some sort of underlying psychosocial issue or anxiety, depression, something else going on that is causing this functional abdominal pain. But again, I want to mention this is true pain. Their stomachs are hurting. There's just not a physiological reason as to why. And then quickly, I want to talk about celiac disease, and you have a good article about this. Again, this is an immune-triggered response that causes gluten intolerance, and so they have to be on a gluten-free diet, and that usually resolves most of the symptoms. Some people will have a lactose intolerance or a cow's milk protein intolerance or cow's milk allergies. And an intolerance is different than an allergy, where an allergy is more of an actual like hypersensitivity, IgE mediated response, where an intolerance is more just like it sounds, like they're not able to break down and tolerate those proteins. So usually we see chronic diarrhea, excessive gas, and abdominal distension, and a lot of times they'll have some growth failure with these syndromes. In celiac disease, a lot of times they'll have iron deficiency anemia just from the chronic inflammation where they're not able to absorb iron. Abdominal distension is kind of one of the red flags for lactose intolerance. A lot of times kids will not be able to tolerate anything with lactose, and the only symptom may be just gas and a bloated stomach. So these are just a few examples of malabsorption syndromes that we see, and some testing that go along with those syndromes. And a lot of these are done, certainly after it's a GI referral, where they'll look further for that. But I did want to discuss the difference between the two most common inflammatory bowel diseases. And again, we know that this is some sort of an immune-mediated response as well to the intestinal mucosa, and is genetically predisposed to certain children. And so there's a strong family link between Crohn's disease and ulcerative colitis. And I just wanted to point out that Crohn's disease and ulcerative colitis are the same exact process going on in the body, but Crohn's disease will affect any part of the GI tract. So this can start up in the mouth and go all the way down to the rectum. So people will have, recurrent flares or exacerbations of Crohn's, and to the point where they're having horrible diarrhea and abdominal cramping and bloody diarrhea. And there may be areas of nice healthy bowel, and then there'll be areas of a really inflamed portion of the intestine. And so symptoms of Crohn's disease, certainly weight loss, failure to thrive, frequent abdominal pain. And the thing we have to remember with Crohn's disease or ulcerative colitis in children, we usually see this more in the adolescent population. There's huge psychosocial considerations that go along with this, and a child that's having like quote unquote emergency diarrhea at school. No teenager likes to go into the bathroom at school, period. And then especially to have this exacerbations of diarrhea that they really almost can't control. So it definitely is a huge effect on their quality of life. And so we're starting to make some progress in treatment for Crohn's, but it is certainly a life-changing diagnosis. So, and again, just want to point out, it can start in the mouth and have aphthous ulcers in the mouth all the way through the intestinal tract. And so basically treating the flares, and they use a lot of steroids to treat the exacerbations, and also now using some other type of medicines that are mostly IV medications that are not steroids, but definitely are immune modulators that have an effect on our response to infection and other things. So ulcerative colitis is pretty much the same exact process, but just in the colon. So we still have the diarrhea, but we don't have the extensiveness as we do with Crohn's. And then failure to thrive in infants. This is usually a multifactorial issue. It's either that the child's not getting enough calories, like the parents are either not feeding the infant, or they're not mixing the formula correctly, or the child's not absorbing the calories, some sort of malabsorption, or they're burning off too many calories. So it's usually 2 to 4, if it's between 2 to 4 months of age in an infant, that's usually some sort of congenital issue. And if it's between 4 to 8 months, that's usually some sort of a feeding problem. So there's all kinds of reasons that infants will have failure to thrive. You have to figure out if it's an actual physical problem with the infant, or if it's a psychosocial problem. This is definitely one area that I've had parents, I've had to put a patient in the hospital and in one of the rooms that they have a hidden camera, and found that an infant that I had worked up completely, checked everything I possibly knew to check, and the baby just was not gaining weight. And the family was they would feed the baby and then they would make the baby vomit. So there's some really unfortunate psychosocial issues that will cause failure to thrive in infants. So you have to figure out if this is a physical problem or a psychosocial issue that's going on. And you kind of have to get a very complete history and do a very complete physical and workup. So failure to thrive is a difficult diagnosis to manage. And one of the main things that you want to check is that kind of that height to weight ratio, because if a baby is increasing in height but their weight is not increasing, then that is usually a sign that they are malnourished and not receiving enough calories. And you also want to check for any type of evidence of abuse or neglect, and make sure that also they have a good suck and swallow reflex. Watch the parents actually feeding them, and then consider there's a whole gamut of other endocrine issues and everything that can be going on. If they have a heart murmur at all, or any perfusion issues or anything, you always want to make sure that there's no underlying cardiovascular defect. If there's a congenital cardiac defect, that will definitely cause failure to thrive, because the infant is not going to gain weight when they're having cardiac issues. They don't eat as well, and there's an increase in calories used just to even try to feed. So this is something that requires interdisciplinary team. I told you sometimes you have to go into the hospital to figure out what's going on with the baby, but most of them do end up growing and developing, may most meet their normal growth parameters. But if this happens in the first 6 months of life, there can be severe developmental and emotional delays because of that inadequate brain development and inadequate nutrition during that critical period. And lastly, I just wanted to show you, you guys may see these in the clinical settings. I just wanted to kind of give you some background on these. On the left side here, this is just an abdominal granuloma. A lot of times after an umbilical granuloma, after the cord falls off of infants, a lot of time they'll have this moist, gooey, kind of whitish tissue that is left after the cord falls off, and it just tends not to dry up very nicely. That is a granuloma that forms, and these are really common. You can take just a little silver nitrate stick and just gently, dab it on the granuloma, and it will turn black and purple and kind of cauterized looking, and it will just dry it up nicely. Those can become infected, but it's very, very, very rare. More than anything, it just takes prolonged time to heal after the cord falls off, and you'll have a lot of oozing and weeping, and can have some bleeding too. So a cord stump, umbilical stump that looks like that, you'd want to put silver nitrate on and just cauterize that, and it does not hurt the infant at all. And then on the right side, that is, you can see that abdominal umbilical hernia. And a lot of times infants will have that until their first year of life because of the weakened abdominal muscles. And as long as you can take that hernia and gently displace it back into the abdominal cavity, then there's no problem with that. So you don't have to do anything with abdominal hernias or umbilical hernias like that other than reassure the parents and let them know that if it became a strangulated hernia, like it started to turn blue or purple and causing pain, then that would definitely be an emergency type situation. But if it's not a strangulated hernia, just a normal umbilical hernia, those usually resolve by their first birthday. And if they don't, you can send them to the surgeon, but most of the time, as those muscles become stronger, those resolve on their own. So that concludes the pediatric GI slide. And what questions do you guys have?